Thank you so much. Thank you everyone for coming. My name is Wassim Chemaitilly. I'm a pediatrician, a pediatric endocrinologist at Children's Hospital of Pittsburgh. And I'm very grateful for, very honored by this invitation to speak to Lending Hearts about my interest in the endocrine complications of childhood cancer. And this is really, I'm going to start just with a few slides that introduce the topic, but this is really meant more as a visit, as a conversation, an opportunity for us to talk and for me to address any questions that you may have. Just a few things about me. So I'm originally from Beirut, Lebanon. I did medical school in France, and then I came to the United States to complete my training. So I did my pediatric endocrinology fellowship at Cornell in New York. Children's Hospital of Pittsburgh was my first job as a young doctor specialist. I came to Pittsburgh in 2008. But then in 2011, I was lured to St. Jude Children's Research Hospital in Memphis. They were trying very hard to recruit my mentor, Dr. Sklar, with whom I had developed my interest in the endocrine complications of childhood cancer when I was a fellow in New York. And he said, I would refer to one of my trainees. And this is how I got to go to St. Jude, where I directed the division of endocrinology, and what was supposed to be just a few years to further my interest in this particular area and get more involved with the academics. Given how exceptional St. Jude is, I ended up staying 10 years before then just deciding to come back to Pittsburgh, where I had kept up with my colleagues here. And I've been back in Pittsburgh as the clinical director for the Division of Endocrinology for the past 2.5 years. And so this is sort of where I'm at. And here at Children's, we are 2 pediatric endocrinologists. There's myself and Dr. Nursing Gertunka, whom specialize in seeing patients who also receive care with the Division of Oncology. So we have a special clinic that we call the Endocrine-Related Effects of Cancer Treatment, or ELECT clinic. We have about, between Dr. Gertunka and I, at least 1 clinic a week where we specifically see patients who are referred to us from the Division of Oncology. And we also have periodic meetings and interactions with our colleague in oncology so that we are their resource locally for any questions that pertain to endocrine issues in these patients. And so with that, I can start sharing my slides and go slowly as we wait for more people to join us. Is that okay, or should I give a few more minutes?
No, please go ahead.
Okay, so let me just share. Can you see my screen with my presentation?
No, not yet. You should be able to have full sharing.
Let me exit from here. Maybe I didn't do it properly.
There we go.
Let me put it in. Do you see my slide in presentation mode?
Yes. Well, it's your screen. Yes, it's available.
Okay. All righty. Very good. So, so I don't have any particular conflicts of interest. And so this is just an information session. And this is the outline of my talk today. So I will talk about, what the endocrine system is, just the basics. And then I'm going to talk a little bit about the effects of cancer and its treatment on this endocrine system, and what are the challenges that patients commonly have across the lifespan in regards to the endocrine system. And then we'll talk a little bit about some of the ongoing research in this area and some resources. And so the basics of the endocrine system. So the endocrine system includes the hormone secreting organs, which are the endocrine glands. And hormones are messengers that carry information between the different organs in our body. The way that I simply explain it to my patients when I try to explain what hormones are is that hormones are responsible for regulating a lot of things that happen without us deciding to do, a lot of the things that happen on their own, things like growing taller during childhood, stimulating thirst or hunger sensation, knowing that we have to go drink or that we should eat, having, cycles, sort of these things that happen on their own, that what we don't decide to do, that's the endocrine system. And so hormones are messengers that carry these messages, for these things to happen. For example, for the bone to stretch taller. And hormones are secreted by these glands or endocrine glands. And the reason why we call them endocrine glands is that hormones are secreted by the glands, the organs that produce them, directly into the blood vessels to be carried around. This is why we say endocrine, meaning towards inside. By contrast to exocrine glands, which produce things that go outside, that don't use the blood. For instance, the sweat glands that produce sweat in our skin, they're not part of the endocrine system because whatever they're producing doesn't go inside the blood. Another example of messaging in our body is the nervous system, where you have signals that go through using the nerves and not the blood vessels. And this is kind of how I contrast to my patients that your nervous system, you decide what you're going to do by and large, where endocrine system, things are happening on their own. And in this cartoon, you can see the different glands that produce the hormones in our body. So there is a center in the brain that controls most of the other glands in the body, and that's called the hypothalamic pituitary axis. So the pituitary is a very small gland on the base of the brain that's right behind the nose, if you want to situate where it's located. And so this, and above it, there's a funnel-like structure, the hypothalamus, that gets prolonged by the pituitary. So the hypothalamus pituitary axis gets all the signals from all over the body, all the information that, hey, I'm about to get dehydrated. Hey, different, I need more fuel, I need more sugar. So the hypothalamus and pituitary get all this information from the body and integrate it. And then they send directions to the different other glands in the body to get whatever is needed to keep the body healthy and balanced. These other glands include the thyroid. So the thyroid is in the neck where my thigh is. It's the gland that's responsible. It's pretty much in our body like our power generator. It regulates how much energy we're burning, we're generating. So it's pretty much like the generator inside a building, like the power generator inside a building. The thyroid decides how much how much energy we need to function normally. For instance, when the thyroid is inappropriately slow, underactive, what we call hypothyroidism, everything slows down. We're tired, gaining weight, not using our stores. We're having problems with constipation. We're feeling cold all the time. And on the opposite, if the thyroid is inappropriately active, like in Graves' disease, we have hyperactivity, the heart is racing, losing weight, etc. The thyroid is also very important for growing taller in children. It interacts with growth hormone, which is a hormone that's produced by the pituitary upstream, and is also important for growth. Another gland going down is the pancreas inside the belly. So the pancreas produces some exocrine secretions that are important for digestion, but also it produces insulin, which is a hormone that's important for blood sugar regulation and for metabolism. Another gland in the body is the adrenal gland. We have two of them. They're right on top of the kidneys. This is why we call them adrenal glands. They have nothing to do with the kidneys. They just happen to sit there. And they produce multiple hormones that are called steroids. And they are responsible for our stress response. And by stress response, I don't mean emotional stress. I mean more medical stress, responding to illness, responding by increasing blood pressure, blood sugar, and mobilizing the immune system. And then lastly, gonads, so the testes in boys and the ovaries in girls, are also considered endocrine glands because they're responsible of producing the sex hormones and are thus responsible for sexual function and fertility. And we also include in the endocrine system, other than these glands, things that are very intimately related to endocrine function. And these include metabolism, so anything that's related to weight gain, weight loss, because it's so intimately related to insulin in particular. but also bone health. The bone is not that piece of stone in our body. It's a very active, very dynamic organ that produces and responds to multiple stimuli in our body. And so bone health is also considered part of what we do in endocrinology, because the strength of the bone is so much a function of the sex hormones, but also of vitamin D and other nutritional factors, vitamin D itself being a hormone as well. And before I go on to talk about the specific issue at hand, which is how the endocrine system is disturbed by cancer and its treatment, does anybody have any questions? All right. So moving on. So cancer and its treatment can have consequences on the endocrine system. As you know, the modalities for cancer treatment frequently occur one of or multiple of the following: surgery, chemotherapy, radiation, and there are also all the medications that are used as supportive care for patients who are treated for cancer. For example, steroids. And so surgery can affect the endocrine system because a gland may be injured because it is where the tumor is, or because it stands in the way of the surgery required to remove the primary tumor in a patient with a tumor or a malignancy. The typical example, for example, is a tumor that we call craniopharyngioma, which is a lesion inside the brain that happens to sit frequently close to the hypothalamus. And so in order to take it out, very often the surgeon has to also take out part of all of the hypothalamic pituitary axis. And this will have consequences on everything that the hypothalamus pituitary axis regulates, effects on the other organs of the body, including growth, puberty, and other endocrine glands. Chemotherapy also affects endocrine glands because the way chemotherapy works, it attacks cancer by pretty much disrupting the growth of rapidly multiplying cells. This is really the property of cancer. And so chemotherapy is a medication that's going to go and target cells that are rapidly multiplying and stop them from growing or cause them to go away. And in our body, some of the endocrine glands, and in particular the gonads, so the testes and the ovaries, have inside them cells that are rapidly multiplying. These are the cells that are responsible for reproduction and which we call the germ cells. And so chemotherapy can affect, because of the particular way with which it targets cell multiplication, the gonads, so the testes and the ovaries. Radiation. So certain glands are very sensitive to radiation and will experience injury, again, if they are situated where the tumor is, or if they are close by, but by what we call scatter radiation. And a typical aspect is how the hypothalamus, thyroid, and also the gonads, the testes and ovaries, are affected by radiation. And also we have the side effect of medications used for supportive care. So many cancer patients treated for cancer require additional medications, for example, to suppress the immune system if this involves bone marrow transplantation. This is particularly the case of the use of steroids. So steroids induce weight gain. They can cause diabetes in a subset of patients. They can also affect the health of the bones and cause fractures and problems with skeletal growth. So these are the ways by which cancer and its treatments can affect the endocrine system. And the way this happens is that endocrine system can be affected right away during cancer treatment, and these are the acute effects. So the typical example, for example, a child with thyroid cancer, they're going to have to undergo surgery to take out the thyroid and will immediately become hypothyroid or have an underactive, have no thyroid and require treatment for it. So this is really an acute effect. What we see a lot in cancer survivors, however, is something different. It's what we call late effects. So effects on the endocrine system that declare themselves several years and sometimes decades after cancer has been treated. And this is particularly how radiation affects the endocrine glands. And this is, the typical aspect. So growth hormone is a hormone that allows children to grow taller. It's produced by the hypothalamic pituitary axis in the brain. So when children receive radiation to the head to treat cancer, the hypothalamic pituitary region is sensitive to radiation. Patients are at risk of having growth hormone deficiency and to have small stature, not grow well because of this deficiency. It is very typical for the growth hormone producing ability in the body to fail, not immediately after the radiation, but 2 or 3 years later. So this is a typical later effect of radiation treatment to the brain. And this particular setup, where effects might happen multiple years after treatment, really require a systematic approach where survivors are regularly screened for whatever they're at risk for at regular interval as part of their follow-up. So because some of it's not that, if you don't get an endocrine complication, you'll never get it in your life. You might still be at risk for it subsequently. And this is why it is so important to receive care as a cancer survivor, especially as a childhood cancer survivor, in a center with providers who are well-versed in the late effects of childhood cancer, and not only in relation to endocrinology, but everything, like our survivorship clinic here at Children's. Because then survivors, after they are done with their short-term follow-up with their managing oncologist, they can transition typically after 5 years of follow-up in their primary clinic, they can transition to the survivorship clinic where they receive at regular intervals and at least yearly all the screening studies that are required for all the things that their treatment exposures place them at risk. And there are guidelines that inform how patients need to be screened. So we have the long-term follow-up guidelines by the Children's Oncology Group. This is a set of guidelines that's available for free on the website of the COG, the survivorshipguidelines.org website. So COG is the consortium that validates and also provides the different treatment protocols for childhood cancer, and also governs a lot of the research that's ongoing. It's a large consortium in North America, and among the things it does, it provides guidelines on how to monitor childhood cancer survivors, and based on the treatments they received, how often, with which modalities, and what to do if something comes as abnormal through these screenings. And so what are the opportunities that we have, and what are areas of active research? So it is very, very important for us as physicians and providers and scientists to disseminate the knowledge that we have, what we've learned through our work with childhood cancer survivors and their families. So it's because not everybody has access to, throughout their lifespan, to tertiary care centers like the ones where we work. So it is very important to disseminate knowledge about childhood cancer survivors, their healthcare needs, the availability of care guidelines to which providers in any setting have free access. So this is very important to disseminate knowledge, grow expertise, and increase provider awareness, and also empower providers to not to be scared when they have a patient with a complex history, but to go out and seek resources and also know where to reach out with questions. It is very important to maintain our engagement and with patients and families and providers, and to work in education sessions like these ones. And in pediatrics is particularly tricky because in a lot of cases, a lot of the conversations that surround cancer treatments and risks that are created by cancer treatments happen with the parents when the child is not able to really be involved or fully engaged in these conversations. And a lot of the things that we discussed with the parents may not be fully understood or transmitted to the child. And then comes the time of the transition to adult care when the child is older and eventually has to take over in terms of decision-making and healthcare decisions and follow-up. So it's always very important for us as providers, but also for the care team, including the parents, to make sure that as the child grows older, that we continue with this process of education and information at a level that the child can understand, so that they are best prepared when the times come to take over their care and know exactly what are the risks they have where they can seek care, and why they need all of that, so that they maintain proper follow-up in order to not delay any care that they need, or not delay any diagnosis that should be made, because of how, in particular, we see these late effects that could set in when an individual who received cancer during childhood could have a health problem related to cancer treatment in their 20s or even 30s or later. And this is why it is also important to continue to better understand late effects and how they feed into general health problems, because the issues I talked about with endocrine glands, they're not only pertaining to, they pertain to various aspects of life. We talked about growth, about puberty, about diabetes. All these things are part of a bigger picture of general wellness, which really affects all aspects of life. So it is very, very important to understand these late effects, how the delay in their diagnosis could feed into worse health outcomes in general. It is also important to keep pace with the times and learn about the effects of new treatments, because it's a constantly changing field, and the approach to cancer treatment has really changed and continues to change and to evolve, which really necessitates continuing to collaborate and not only look at prevalence and risk factors of problems, but also how to intervene and mitigate some of, as much as we can, the effect of complications from cancer treatment, and work on towards precision medicine, earlier diagnosis, and earlier treatment to improve these outcomes. And so this is the primary resource that I would recommend to you all to know about, the survivorshipguidelines.org, which is the Children's Oncology Group long-term follow-up guidelines. The Children's Oncology Group website has a lot of information related to childhood cancer survivors, and not only obviously to endocrinology, but all late effects. In addition to a lot of handouts, a lot of easy, simple explanations pertaining to the different organ systems. And with that, I am going to stop this very short presentation to take any questions, and I will stop sharing.
I'll start with a question, Doctor. When you mentioned, if I'm following correctly, that by having the cancer could maybe lead later to diabetes as one of the repercussions, could it happen the other way around? Somebody with diabetes be more prone to, say, a pancreatic cancer or something like that because of, could it flip-flop in that manner or no?
Having diabetes per se is not a known risk factor for having a malignancy. There are some data in the general population that have associated having obesity as a potential higher risk for malignancy. And as we know, obesity is also a risk factor for type 2 diabetes, the diabetes that's associated with a family history, and that tends to be more prevalent than the insulin-dependent or type 1 diabetes. So I will say that there is no clear association between diabetes and cancer risk, but they could both be related to certain bigger or more general health risks, including in particular obesity.
Okay. Doctor, you said that getting chemotherapy some of the glands that might be around where, let's say, the cancer was, and the maybe that would affect them later on in life. Did I understand that correctly?
So chemotherapy tends to affect primarily the reproductive organs. It can have some other effects, but it's primarily the reproductive organs. It's really radiation. So radiation, which could affect glands that are in the way of where the radiation was given. And that also can affect the endocrine system, where you can see problems happening several years later, what we call the late effects.
Okay. So with the chemo that could affect my daughter that well, we found out later that she had her, what was it?
Ovarian failure.
Yes. So
Hmm.
that was from the chemo. Can that be reversed as she grows older, or is that going to, with the, she's been taking
Birth control.
birth control pills and stuff, could that get reversed later on, or is that pretty much doomed?
So both chemotherapy and radiation can affect the ovaries and the testes, the reproductive organ, because both chemotherapy and radiation, they target cells that are rapidly multiplying. This is the property of this is the property of cancer cells. And so both can affect the ovaries and the testes. So in relation to the ovaries, when doctors diagnose premature ovarian insufficiency, which is what we say now more to describe, it's equivalent to ovarian failure, it generally means that there's been damage to the ovaries where they are, we suspect that they will not be able to function for a given number of years. Usually, what happens, any child who receives chemotherapy or radiation with potential to affect the ovaries, regardless of recovery, might have the ovaries that shut down for a couple of years before we start the ovaries going back to function, if we are within the age that's consistent with puberty. So I'm not talking about the 5-year-old who receives chemotherapy. That child obviously is not supposed to have puberty until much later in life. But I will say that, for example, a child who's 14 years old had gone through puberty completely, and then puberty stopped during cancer treatment, we would anticipate that chemotherapy is going to put the ovaries at rest for a couple of years, and then eventually we can start the ovaries recovering and seeing them function 2 to 3 years later. If we don't see that happening, it is likely that the ovaries will not recover. So the answer to your question, it depends if whether we're still in that window where doctors are waiting to see if the ovaries are going to recover, and that they might make the decision at some point to stop the estrogen replacement or which is given often as a birth control pill, to see if things will happen on their own again, or whether they've already made the determination that it is very unlikely. So it all depends on the context and what your doctors have said. But generally, if they've waited, if the child had puberty before or was of age where puberty would be expected after the age of 12, if they've waited for a couple of years, did blood work, and think that there's not going to be a recovery, it is possible. So it is a question to discuss with your doctor, because it all depends on the context, what they've tried before, and also some of the labs. Sometimes blood work will help predict what's going to happen. But I will say that birth control is not a treatment that will help the ovaries recover. It's not something that's intended to make the ovaries work again. It just does their job so that there are signs of puberty and the bones are healthy, getting the treatment with estrogen that's needed for the bones to be strong.
Okay.
Does that answer your question?
Mm-hmm. Yes.
And this is a very, it is a very difficult, it's a very difficult conversation, because ability to have children is something that's very important for childhood cancer survivors and their families. And the landscape for that has changed considerably. I would say over the past 10 years, we have more and more what we call fertility preservation, where we have a fertility team, for example, here at Children's, whom as soon as cancer diagnosis is made, and if there's a window of opportunity, they will come and talk to the family and to the child and discuss opportunities where some of these germ cells, the cells for fertility, could be preserved, so taken out and preserved and stored in a bank and eventually used later after cancer treatment. So fertility preservation is something that's become more common, more readily available, and we have a fertility preservation team here at Children's to counsel families, so that this is a very active area of research in the field, because we may not be able to completely prevent the effect of cancer treatments on the reproductive ability of survivors, but there is more and more effort trying to preserve that capacity prior to exposure to cancer treatments.
What's the youngest age that they would consider working with a patient? I'm just curious.
Any age.
Oh, really?
Any age. And I think right now it is really in the protocols of the oncology team to have conversations about fertility if they anticipate a toxic effect on the gonads. I've seen an infant get fertility preservation in our hospital, recognizing that some of this might be research, there might be some limitations to some of what can be done, but these are conversations that are had with families and with patients regardless of age.
I have a quick question. The previous question kind of answered it, but I just wanted to reiterate. I was 15 when I received chemotherapy, and I noticed about a few years ago, so about a decade after treatment, that there was some hormonal changes. And my first thought was, oh, maybe it's just because I'm in my mid-20s and this is what a woman goes through, or could it be possible that there's a link between receiving chemotherapy kind of at that end stage of puberty and now seeing that a decade later there could have been some impact on the hormones and reproductive system?
What happens with girls is that all girls are born with a given number of oocytes. So oocytes are the cells that get fertilized eventually to have a baby. So all girls, from the moment they're born, they have a given number of these oocytes in their ovaries, and this number goes down very quickly, normally, naturally. Is what physicians and scientists call atresia. So it is normal for girls to lose over time the number of follicles. And then eventually when all of them are depleted, this is when menopause happens. Cancer treatments such as chemotherapy or radiation, right there and then during the exposure, are going to reduce the number of follicles to a certain number. And then the remaining follicles are going to continue to go away through the natural process of atresia. And this is why, even though cancer survivors might be able to go through puberty and have menses for a given number of years, they might still be at risk for experiencing menopause earlier than the age of 40, is what we call premature menopause. And this is why one of the things that are interesting, and it's a little bit counterintuitive. One would always think of small children as more vulnerable in general to problem. This is one area where if you receive the cancer treatment at a younger age, you already have a lot of follicles. So even if cancer results in some loss, you're actually at a lower risk than somebody who receives treatment at the age of 16 or 15, where a lot of this natural atresia process has happened. I will say that now in reproductive medicine, there are things they can measure, such as the anti-Mullerian hormone. There are also particular ultrasounds that allow counting the follicles, what's called antral follicular count, that helps kind of understand what the risk is for a survivor who got this particular history, because there is still the opportunity to harvest oocytes and preserve them for later. If the survivor is on this trajectory and is not ready to have a family right away. And so again, I wouldn't want you to share personal information more than you need to, but if you are, definitely worth getting an opinion about from a fertility specialist to assess status and see what could be done, because it's not, there are also things that can be done to, if indeed this is the trajectory, to preserve the fertility potential. It's not only at the front end before cancer treatment, it continues because of the risk of premature menopause in at-risk individuals. And this is why it is so important to maintain care with providers who know these things and can properly counsel patients and families.
Yes, thank you.
We had some pre-submitted questions. Were you able to answer those, Doctor? Or I don't know if we touched upon them.
Sure. So one of the questions that came was that there was a concern about the hair loss that happens during chemotherapy and how a child was not able to recover proper hair growth despite consulting with a dermatologist and getting topical treatments such as minoxidil. I will say that this is out of my area of expertise. It's not related to hormones. And so minoxidil is really the primary resource that is used by dermatologists, but it is the effect of the chemotherapy on the hair follicles and how to mitigate that and treat it. It remains within the realm of dermatology. I don't think that there is anything in particular that can be done on that end. The other question that I had was in relation to the lasting effects on treatment with steroids. And this question came twofold. So steroids are medications that are used either to treat cancer, such as leukemia, and in which case patients are on steroids for sometimes for 2 years or longer. But also steroids might be needed longer term for some of in certain patients who are treated with bone marrow transplantation, as in order to allow the patient to maintain the graft, in order to stop graft rejection. So in all cases, steroids are very, very widely used in patients during and after cancer treatment, and they have a lot of side effects. So the first question pertained to effects related to weight gain and irregular cycles and prediabetes. So people who receive very, very high doses of steroids have a very high risk of developing abnormal weight gain. Steroids fuel appetite, and in particular appetite for things that increase weight, such as carbohydrates and sugars and sweets. And exposure to steroids during cancer treatment comes at a time where the child is particularly vulnerable. So the child is going through cancer treatment, a lot of emotional distress, a lot of fear around the child. So, a lot of times sweets and sugars and food is used as a treat. So, well, what else are you going to deprive this child from? And so I think that it's not unusual for children to gain a lot of weight because of steroids during cancer treatment. And there are a lot of studies that have shown that some of this weight continues years after cancer treatment is done and represents really a threat to the child later on in life because it induces higher risk of type 2 diabetes. So I think that, yes, treatment with steroids can increase the risk of persistent weight gain. And this is why it is very important during cancer treatment to still try and maintain healthy lifestyle and avoid the excessive consumption of sweets and junk food. It is particularly important to maintain that after recovery from cancer and to increase physical activity as tolerated, because the effects could be long-lasting. And obesity and diabetes and prediabetes, I'm talking about type 2 diabetes and insulin resistance, which are caused by steroids but could happen on a backdrop of familial predisposition, can also interfere with cycles in women and contribute to what we call polycystic ovarian syndrome, or PCOS. And so this is how long-term exposure and prolonged exposure to steroids can have that effect. And so it is very important, again, to maintain healthy lifestyle, to try to work with providers who are versed with these late effects and to see ways where some of this can be reversed over time. So this was the first question. Could have the steroids influenced my health later on in life? And the answer is yes. And we try to intervene as early as possible so that the effect is as limited as possible. But these remain very frontline treatments for leukemia. And so sometimes there's no other way. The other question pertained to the effect of the steroids on the adrenal glands. So the adrenals are responsible of the production of the body's natural steroid. And if we get a lot of steroids from outside to treat cancer or as medications, they can make our adrenals lazy. And it takes time for the adrenals to start producing again the steroids that our body needs so badly. So the natural steroid or cortisol is very, very important for us. Without it, we're vulnerable to infections. We can have what we call adrenal insufficiency, which is a condition where if we get sick, we can experience low blood sugars, hypoglycemia, seizures, and also can have shock, hypotension, and even death. So the body's own steroids, cortisol, is extremely important. And so this is why in individuals who receive steroids for a while, I will say at high doses for over a period of 2 to 3 weeks, generally the doctors are going to go down on the dose of steroid very, very, very gradually, and eventually will ask us in endocrinology to take over with just natural replacement with hydrocortisone, which is the medication that resembles most the body's natural cortisol. And then we have a whole bunch of tests that will help us verify whether it is possible to withdraw that or not. So this was the other question about adrenal insufficiency and long-term treatment with steroids. And why do we need to go down on the doses slowly? Or sometimes we have patients stay on hydrocortisone for a little while before we can take it away. I think these were the 3 questions that I had gotten online before the session. I don't know, Vasu, if you had any other questions that came through or if I had forgotten something.
No, that was it. I personally have just one last question. You mentioned vitamin D earlier. Did you say it acts as a hormone, or, you know,
Yes.
if somebody goes through treatment, should as you're aging or you're going towards menopause, be taking supplements? What's the protocol for vitamin D?
So vitamin D is a hormone, and interestingly, it is related to steroids. It belongs to the family of steroid hormones. So vitamin D is produced mostly under the action of the sun in the skin. And so this is why individuals who spend a lot of time indoors generally are deficient in vitamin D. But also this is why where people who have darker skin don't have as much of an easy time producing it as others. And so vitamin D is produced mostly under the action of the sun. We also get some vitamin D through nutrition. Some of the foods are fortified in vitamin D, like dairy. And vitamin D is very, very important for the health of the bones. The bones need vitamin D in order to renew the minerals in them. And without vitamin D, we can have a condition in children that we call rickets, which is soft bones, where the bones bend because they don't have good mineral and structure in them. And in adults, it's a condition that we call osteomalacia in its extreme form. So vitamin D is extremely important for bone health. And I will say that most people with a regular modern lifestyle, with us sitting indoors and working on computer and not getting exercise, or just living in areas that don't get a lot of sun, have a risk for vitamin D being deficient or insufficient. So it is very important. This is particularly it gets another level of urgency in people who already are at risk for brittle bones because they were exposed to steroids. Steroids make your bones brittle because they've had challenges in terms of nutrition and growth, because they may have physical limitations where they cannot be outdoors exercising all the time. So I will say that childhood cancer survivors are particularly at risk even more for vitamin D deficiency. So it is important to have the primary care physician check vitamin D levels and give vitamin D to supplement it and bring the levels to a normal value. And so one of your questions is like, why don't we just get supplements? It is sometimes the supplements that you find over the counter in pharmacies, although they say this satisfies your daily requirement, they may actually not be enough if you are profoundly deficient in vitamin D. So this is why some of the studies that were done in childhood cancer survivors, where they've looked just at effect on bone or just meeting the daily requirement, may not have panned out in better bone health, just because maybe the deficiency was more profound, where you needed to measure the vitamin D and then get enough vitamin D, probably more so than what's in these supplements, to get it back to the normal range. That's why I think it's important to ask doctors about whether an individual is vitamin D deficient, and then how much vitamin D is needed to get that level to normal, and then verify that it's been back in the normal range. I will counter that vitamin D deficiency is so frequent in this particular area of the world where we don't have a lot of sunlight, that it should be part of the health screenings that are done by primary care physicians yearly, and that people who really are at risk for it just because of, their lifestyle or other limitations should be on vitamin D supplementation. It's possible that vitamin D plays other roles. Sometimes I feel that we give it too much credit and other things. Nowadays, you can see vitamin D everywhere. Vitamin D is important to prevent this or prevent that. But I will say that its proven effect is primarily on bone health.
Thank you. This was so informative. I don't know if there are any other questions or.
Well, I really appreciate this invitation. For me, it's always a joy. I'm so passionate about childhood cancer survivors and ensuring the best possible for me. And I tell my patients, I'm so passionate. I just want you to do so well for so long. For me, it's never a problem. And so please, if you hear from any of your group, anybody who has any questions, it's never a problem for me to reply. And I really wish the best for all of those among you who are present, and please don't hesitate to let me know if you have any questions. Okay.
Thank you. Thank you so much. Really appreciate your time and everyone else's.
No problem.
Thank you.
Have a good night. Thank you so much.
Thank
Bye-bye.
you. Have a wonderful evening. Bye-bye.
Bye.